So I want to welcome everybody back. I also would really like it if those of you who are here could maybe move a little bit closer, make this a bit more intimate. Those of you who absolutely insist on hanging out in the far back, that's fine, but to come forward. This session is going to be devoted to advanced stage 4 recurrent non-small cell. You'll learn about some of the latest techniques to treat lung cancer that's moved beyond the confines of the chest or has recurred and is not necessarily adaptable to surgery. You're going to hear short presentations from a couple of my colleagues as well as myself, from pulmonologist Dr. Moon, from radiation oncology, from Joshua Jones, and myself on our specific approaches to folks in this situation. So without further ado, I want to introduce Dr. Moon, who's going to talk about new diagnostics and new local therapies for pulmonary recurrence. Ed?
Good morning, everybody. I'm having myself some troubles thinking in this cold room, but please try to pay attention. It is a little cold in here. I want to underscore 2 points that have maybe been noted so far this morning by the excellent group of speakers. One is, I'm sure that after hanging out with a bunch of us for a good part of the day, you'll be very familiar with many of the achievements at Penn. But I want to remind all of us that today is celebrating not Penn's achievements first and foremost, but celebrating your achievements. And the issue is, how can we help in you attaining achievements in the future in your fight against this deadly disease? The second is, they've asked us to confine our talks to 10 minutes. That doesn't mean that I only have 10 minutes worth of services to offer patients like you. It means that this is just simply a reflection and a tip of the iceberg in terms of the things that we can offer as pulmonologists. So what does a pulmonologist have to do with lung cancer? Well, it's in the lung, obviously, but what sets us apart from many other pulmonologists in the community is that pulmonologists at Penn, especially a small group of pulmonologists called the interventional pulmonologists, really not only help diagnose lung cancer, but also are very invested in following and treating through the course of lung cancer with our colleague oncologists, radiation oncologists, and surgeons. So we're going to be talking about advanced or stage 4 lung cancer. What is advanced stage 4 lung cancer? Well, it's defined by the presence of distant metastases. What's distant metastases? Well, it's really the spread of tumor from one organ, the originating organ, or part, to another non-adjacent organ or part. So what are examples of distant metastases? So if you have separate tumor nodules in the lung opposite from the lung with the original tumor, that's one example. If you have tumor nodules in the lining of the lung, also called pleural nodules, or tumor cells in the fluid that's between the lung and the chest wall, there's normally a little bit of fluid there. That's also called a malignant pleural effusion, or tumor cells in the fluid surrounding the heart, or also called a malignant pericardial effusion. Or the third example is if you have distant sites of tumor outside the chest. So as a pulmonologist, I'm going to be dealing with 3 examples from this set of examples of distant metastases. One is separate tumor nodules in the lung opposite from the lung with the originating tumor. The other is tumor nodules in the lining of the lung. The third is the malignant pleural effusion, tumor cells within the fluid that normally sits between the lung and the chest wall. One role that I have is helping diagnose these distant metastases. So the 3 examples that I help diagnose are in the opposite lung, or in the lining of the lung, or in the fluid that sits between the lung and chest wall. So let's say an individual has lung cancer in the left lung. The first example is you end up with lung cancer in the opposite lung. Or you have lung cancer that sits in the lining of the chest. Or the third example is you have tumor cells found in the fluid between the chest and the chest wall. So one example is in the opposite lung, the other is in the lining of the chest, or one in between the lung and the chest wall. One modality we use is bronchoscopy. Some of you, or the majority of you, may be familiar with this procedure. It's a way that we help diagnose lung cancer as it originates, but also help diagnose whether or not lung cancer has reoccurred in the other lung specifically. It's a camera that's the caliber, which is the size of a pen or smaller, and goes through the windpipe. It can go into either the right or the left lung. We can pass different instruments through the bronchoscope to help diagnose whether or not there's tumor cells within a certain area of the lung. We have certain tools that help improve the accuracy with which we can diagnose lung cancer with the bronchoscope. One is the endobronchial ultrasound guided bronchoscopy. And what this does is, just like women can get an ultrasound when they're pregnant, there's also an ultrasound probe at the end of the camera that helps us to see objects that are outside our normal field of view. And then there's a needle that goes into the lymph node or it goes into the tumor that helps us to find tumor cells if they're present. And this can be done either with a large ultrasound probe within the middle of the chest or way out in the edge of the chest with much smaller ultrasound probes. There's also what's called navigational software. So with the technology of CT scans these days, we're able to take the cuts from the CT scans and create a three-dimensional reconstruction image, which allows us to help navigate through the airways, especially as the airways start branching into much smaller airways. And instead of having to, by trial and error, go into many of these minuscule airways, we can pinpoint for efficiency of the procedure which airway needs to be explored in order to get to the lung cancer seen on the CAT scans. What about diagnosing distant metastases or tumor in the lining of the lung? Well, we, along with our thoracic surgeon colleagues, are developing pleuroscopy. They do what's called video-assisted thoracoscopy, which is done under general anesthesia. But there's also pleuroscopy, which is done by pulmonologists with conscious sedation while you're not totally asleep, where we put in the camera, similar to the bronchoscope, this time into a small incision in the chest wall. And it allows us to see the lining of the chest, the lining of the lung, to see if there is obvious tumor nodules that invade into the chest wall. And we can pass different instruments through the pleuroscope, like we can through the bronchoscope, to get access to those nodules if they're present. What about diagnosing distant metastases in the fluid between the lung and chest, the third example? Well, you can do this by pleuroscopy, but we can also do this at the bedside in the office, which we commonly do via a procedure called thoracentesis. After we've ultrasounded the chest to make sure there's a very safe pocket of fluid that's concerning for involvement by the tumor, we locally anesthetize that area, and then we insert a small needle, allowing us to drain the fluid and send it off to the lab for studies to look for tumor cells. The second role of the pulmonologist. So we talked about diagnosing the distant metastases. Like I said, one thing that sets us apart from many of the other pulmonologists in the community is that we also help take care of and care for the symptoms that may be caused by stage 4 or advanced lung cancer. And this is symptoms caused by distant metastases, specifically speaking, the symptoms caused by fluid between the lung and the chest wall. So if you think the chest is a confined cavity with a defined amount of space, and if you have lung in that confined cavity, but it's being pushed aside by fluid that starts building up as a result of tumor involvement, the lung has less and less space to expand and can cause shortness of breath. So we have ways to help alleviate that symptom. One of the main ways we help alleviate that symptom is by draining it. We've come up with a device that we pioneered at Penn, where we place a tiny catheter into the chest, and it's tunneled so that the skin scars down at the midpoint of that catheter, separating the outside world from the inside of the chest, thereby decreasing greatly the risk of infection. And this way, you don't have to come into the office to get it drained every time the fluid reaccumulates. This is a procedure that can be done in the operating room, in the procedure room, or even at the bedside. Can be done under general anesthesia, can be done with light sedation, or with just local numbing. It allows you to not only get drained in the hospital repeatedly without having to get stuck in the chest each time, but also can get drained at home. And we have services in place where home aid nurses can come out, show you how to drain it, and if you have enough family or friend support at home, they can also learn how to drain the fluid. And this has proved to be a great tool in helping alleviate the symptoms of shortness of breath when there's a lot of fluid that reaccumulates in the chest. Another procedure that's done is, well, what about getting rid of the space that's in between the lung and the chest wall where the fluid can reaccumulate? And that's what's called pleurodesis. So if you can imagine, if there's fluid here that's taking up space in between the lung and the chest wall such that the lung can't re-expand to its normal size, causing you shortness of breath, you can put a tube in here, evacuate or empty out the fluid, and then put in different types of chemicals to help scar the edge of the lung against the chest, thereby eliminating that space that's there, preventing the fluid from reaccumulating. There are pros and cons between the two procedures, which I can discuss in person if you'd like. The third role of the pulmonologist, and this is probably the slide that gives me the most excitement to talk about, is advancing treatment of distant metastases through new approaches. So I've had the privilege at Penn, with many other research partners, of helping bring a specific type of therapy called immunotherapy from the bench to the bedside for another type of cancer, mesothelioma, which is being discussed in the next room. And we're slowly starting to explore expanding this treatment towards lung cancer. So it's one slide, but there's a lot of ideas behind this one slide, and one main question behind this one slide. The one main question is, well, how come our bodies, namely our immune system, how come our immune system is very easily able to fight off the common cold? The cold is a foreign agent that invades our body, and our immune system takes care of it. Well, the tumor cell is no different. The tumor cell is a foreign agent that invades our body, but why is our immune system not able to overcome that foreign agent like it does with the common cold? Well, we've explored several different answers, and one is that the immune system is tricked by the tumor cell into thinking that it's not a foreign agent, and it's actually part of the body. So what we do is we've come up with ways in the scientific world to analyze the immune cells of people who have different types of cancer, find out what defects are in those immune cells, and then genetically modify those immune cells to overcome those defects. So now they properly recognize a tumor cell as a foreign agent. And to our great delight, the first patient with mesothelioma has been treated with this type of new therapy called immunotherapy, and we're waiting to find out, one, if they tolerate the treatment, and two, if it has any effect. So this is still in its brainstorming stages, because lung cancer, like many other cancers, have many tricky ways of convincing the immune system that it's part of the body, not a foreign agent. But the idea is to take one's own immune cells out of the body, analyze them, modify them to overcome their problems, expand them in great numbers, and then reinfuse them back into the patient to allow them to now recognize cancer and fight them off. So with that said, I want to thank everyone for coming, and again, though 10 minutes of discussion through slides, it's just a tip of the iceberg in terms of what the pulmonologists at Penn have to offer for you in helping you fight this disease. Thank you.
Any questions for Dr. Moon? There'll be time for a roundtable at the end, but any specific questions about what he has presented? If you can go to the microphone, please. I think for the next speaker, I'm going to be Oprah, and I'm going to run around the audience with a microphone. You're probably thinking, this doctor has actually seen Oprah? Never.
Yeah. Hi, my name is Melody, and I'm going to try to get this question, the thought that I have in my mind, and
Sure.
hopefully it comes out the way I want it to.
Yeah.
think I understood you to say that what you do as a pulmonologist, uh, this latest thing with getting the lung cells and then putting them back into the body, teaching them to fight cancer, and then putting them back into the body. Is that what you said?
Correct.
Now, is that a process? Is that a new process that has come about? And if it is, what's the name of that new process?
So the name of this process is called T-cell immunotherapy. It's not yet available for lung cancer. It is available and has been shown to be very beneficial in other types of cancer, melanoma, renal cell cancer, and now we're testing it at our hospital in mesothelioma. There are many preliminary steps that have to be looked at in the laboratory
Okay.
to see what is it about the immune cells in the context of lung cancer
Okay.
that needs to be overcome and need to be modified in order for the effects seen in melanoma and renal cell cancer and hopefully mesothelioma can be seen in the future in lung cancer as well.
Okay, great. Thank you.
Sure.
Any other questions? I just want to make one comment on that, this is sort of the new vanguard of research. It's always been out there, but the notion that we can somehow teach or inform our immune system to help combat the cancer as opposed to just bombard the cancer with some sort of external agent. One last question before we go on to the next speaker.
Since now we're discovering that there are some gene-targetable therapies like Terceva and crizotinib, apparently we have a key to a lock that we know we can get something to cancer cells specifically. Is there any prospect for being able to detach something of an immunotherapy kind of thing that will say that you would attach it to that key? It would find its way through the system to the cancer cells and would basically say, hey, immune system, I'm here. Get me.
Basically
you already have
directing
the
it
key.
toward the proper tissue.
Mm-hmm.
So that's also I promise everybody I didn't plant him in the audience to ask the question. But there are many ways to do that, one of which is identifying chemokines that the body normally uses to attract cells to certain parts of the body. And part of my research has also been, well, how can we appropriately cause agents that we introduce in the body to fight cancer to appropriately target cancer? And if you can think about it, that logically makes sense, because if it doesn't target normal organs, maybe you can prevent extreme side effects, maybe you can lower the dose of the agent you provide. There are many avenues in research being done, and the particular area of research that's my interest is to use chemokines and profile tumor cells in terms of the chemokines that they secrete and augment immune cells to bear the receptors that recognize those chemokines so that they can traffic towards the appropriate tumor cells.
But it's very tricky, and unfortunately a lot of normal cells frequently have the same receptors. So
Correct.
you may be directing this new therapy to the cancer cell, but also a concentrated dose to normal cells, and that's been one of the main impediments to developing this sort of research. But stay tuned. Thanks. So I'll actually go out of order. Our next speaker is going to be Dr. Jones from Radiation Oncology. He's going to talk about specific interventions that can be done through radiation, including some of the newer techniques. And then I'm going to finish up with the more conventional systemic approaches.
Thank you, Dr. Langer. My name is Joshua Jones. I'm one of the senior residents in radiation oncology, and my specific area of interest is actually the utilization of radiation therapy in advanced cancer. So that's what I'll be spending a few minutes talking to you about today. So I want to start by answering the question, what is radiation therapy? Radiation therapy uses high energy X-rays, so it's similar to a chest X-ray. You don't feel it, it is painless. But using these high energy X-rays that we are able to aim specifically at areas of cancer, we're able to utilize this treatment to kill cancer cells. What I want to emphasize is that radiation treatments are very localized treatments. So we can treat an area in the lung, we can treat an area in bone, we can treat an area in the brain. But the radiation does not go everywhere in the body. And so we reserve radiation treatments for very specific local areas once the cancer has spread outside the lung, once the cancer has become metastatic. But I want to talk more about what those indications are and how we think about it. So I also want to just take a moment to talk about who the members of the radiation oncology team are. As our panelists from this morning discussed, at Penn we have a very large interdisciplinary group. Well, within radiation oncology, patients will meet many individuals who will be caring for them. A question that I often get is, doctor, will you be the one who's actually administering the radiation treatment? Well, it's a team approach. There's a radiation oncologist, a nurse, there's a therapist. The therapists are trained, licensed individuals who deliver the treatments. We also work with dosimetrists and physicists who help us to figure out what is going to be the optimal approach to treat the specific area in question. So you'll meet the physicians and the nurses and the therapists, but it's a whole team that works behind the scenes to provide optimal care in targeting the radiation to exactly where we want it to be delivered. So what are the indications for radiation therapy in advanced lung cancer? There are really two specific indications that we think about. So one is for local symptom relief. So if there's an area that the cancer has spread that is causing symptoms, it's causing difficulty for the patient, we think about it in that setting. We also think about it using it in brain metastases when the cancer had spread to the brain. What I want to focus on is that the decision for the type of radiation treatment and how the radiation is delivered, even the number of treatments, is a very individualized decision. The goal is to provide the most effective, safest treatment with the fewest possible side effects. Obviously, our treatments wouldn't be very helpful if they had lots and lots of side effects that were unmanageable. So that's our goal. And when a patient meets with a radiation oncology team, that's what we're going to be focusing on. So for local symptom relief, I'm going to focus primarily on external radiation. We can treat patients to help relieve pain, particularly when tumors have spread to bones. They can be very symptomatic, cause pretty significant pain. Radiation can be very helpful with that symptom. Sometimes with bleeding or with shortness of breath. Sometimes the tumor within the lung itself can become very advanced and can cause irritation within the airway, can cause bleeding within the airway, can cause shortness of breath because it's closing off the airway. And in that circumstance, sometimes radiation treatments can be very effective at helping with the bleeding and helping with the difficulty breathing. I wish I could tell you that we have 100% effectiveness with these treatments. Looking at studies over the last 30 or 40 years, the external radiation treatments, somewhere between 40 and 80% of patients will have a response to radiation. The 40% could have a complete response and have full relief of those symptoms. Some patients may have a partial response. So what's the process for this? The first step in this process is a consultation, meeting with a radiation oncology team. And I put this up because this is something that many of my patients have questions about. The simulation is where we actually do a planning scan, a planning CAT scan. Most patients say, Doc, I just had my CAT scan last week or 2 weeks ago. Why do I need another one? Well, the CAT scan that we do is specifically hooked up to our treatment planning computers. It allows us to target the radiation so that we can target the tumor and minimize the radiation dose to normal tissues. Once we've done that, daily treatments can range from a single treatment 1 day up to 3 weeks. And during that time, you'd be meeting with a radiation oncology team regularly and then follow-ups. So this is that simulation, the planning session. You saw the CAT scanner that Dr. Turigian put up earlier. This table is a little bit different. It's very flat so that we can get you in exactly the same position every day, and we can target the radiation where we want it to be delivered. The external treatments that I'm talking about when we're thinking about relief from pain, from shortness of breath, are delivered with a linear accelerator. That's the machine that actually allows us to deliver these high energy x-rays and target them exactly where we want them to go, hit the tumor and miss the normal cells. That's the conventional, the standard radiation therapy that we've been thinking about for many, many years. Side effects I just want to mention because everybody has questions about these. Fatigue, skin changes, the skin can get like a light sunburn. But other side effects are going to depend on where the radiation is delivered, to the bones, to the lung, et cetera. And I'm happy to talk to anyone individually if you have specific questions about radiation therapy. I was told that there were many questions about the long-term side effects of radiation therapy. They are rare, but I'll talk a little bit about those in a moment. Specifically, the questions that people had asked me about are what are the long-term side effects of radiation therapy when we're delivering radiation to the brain, because this is the other major area where we do treatments in lung cancer that's spread to other areas. So when we're treating the brain, there are two different types of treatments that I want to talk about. So with many lesions, when we see that there are lots of different spots within the brain, we can think about whole brain radiation to the entire brain, or we can think about some of the more advanced techniques, the newer techniques that we've been looking at for the last 10 years and that we're still studying to figure out what the best way to utilize these treatments are, and that's with stereotactic radiation. And so I divide this into two different basic types of treatments. When there are lots of lesions, we generally think about doing a combination of radiation to the whole brain with potentially the stereotactic, more advanced radiation. With a single spot in the brain, or only a few, one, two, or three spots in the brain, we may think about doing surgery. We may think about doing stereotactic radiosurgery alone and not doing radiation to the whole brain. The way that I think about this, the analogy that I tend to use is thinking about a garden. And when a weed appears in the garden, we want to get rid of that weed. And so there are two different ways that we can think of doing that. If there's a single weed, we can pull the weed. That's the stereotactic radiation. Targeting just to that one or two or three spots is weeding. But if there are lots and lots of weeds, the concern is that without using some type of herbicide or something else that's going to prevent the weeds from coming back, we may not be able to get full relief. And so when we think about doing whole brain radiation, we're delivering low doses of radiation to the entire brain with a goal of treating everything, including areas that we may not be able to see but are probably there, trying to keep those spots from coming back. So with whole brain radiation, we end up making a mask at the time that we're doing that planning session. The mask, as you see here, is plastic. It is mesh. It is see-through. You can breathe through it. And it's made individually for every individual who comes in. The mask gets placed over the face and will be on an average of about 10 to 15 minutes per day during the treatments. These treatments are somewhere between 2 and 3 weeks long. I put the second picture up here with the lasers. That's what allows us to target the radiation, be absolutely certain with millimeter precision that the radiation is going exactly where we want it to go. Treating the whole brain, that's important. We want to be able to treat the brain, but miss things like the throat, which would cause bad sore throat, miss the eyes so that we don't cause dry eyes, don't cause extra symptoms. So we use these masks and the lasers to target the radiation to within millimeters of where we want it to be delivered. Stereotactic radiosurgery, I want to take a moment to explain what stereotactic is. So stereotactic is a fancy word that means that we are using any number of different techniques to very precisely target where the radiation is delivered. It allows us to give very high doses of radiation. There are multiple different machines that will do this. So you may hear commercials for CyberKnife or tomotherapy or BrainLab or TrueBeam. All of these are different ways of saying the same thing, that we're using stereotactic radiation to pinpoint very precisely high doses of radiation to small areas. The two machines that we have at Penn that do stereotactic radiation to the brain are the Gamma Knife, which, as you see here, uses, it's actually different, the pointer. Got it. So the difference with Gamma Knife is that we're no longer using this linear accelerator. Instead, we have a machine that has a helmet with 201 different sources of radiation. Those 201 different sources of radiation can be pinpointed to those little tiny areas that we need to treat. So we spare the vast majority of the brain, and we're able to focus the radiation just on the areas that we want to treat. This treatment with Gamma Knife radiation is done in 1 day. But again, the discussion that your radiation oncologist will have with you is whether to target focally or to treat the entire brain. SBRT, stereotactic radiation, can also be used, and this is the area where I think we're starting to do much more research, thinking about using that targeted radiation outside of the brain and other areas of the body. So I mentioned the CyberKnife unit. This is actually a very small linear accelerator that's mounted on a robotic arm that is actually able to move in lots of different directions. So we're able to use, as you see here, lots of different ways of aiming the radiation into the body to target those small lesions with high doses of radiation while sparing the normal tissues around them. And what we're trying to do and what we're trying to figure out is, when is this stereotactic radiation, the highly targeted radiation, beneficial in comparison to the external radiation, which we've been using for a very long time, is a larger, wide open area that gets relief, but is not as focused as this. So as we move forward, what are the areas that we are looking at? We are looking at these questions of, when cancer has spread outside of the lung, when it is in other areas, what are the most effective ways to use radiation to treat spots in the brain, to treat spots that are causing problems elsewhere in the body, with both the external radiation and these more targeted stereotactic radiation techniques to provide symptom relief and to provide optimal care for our patients.
Questions for Dr. Jones? If you can come to the mic, or better yet, I will come to you.
Thank you. Doctor, the SBRT, I have stage 4 metastatic. Actually, Monday will be 5 years since I've been diagnosed with it. And it's in my lung and I believe my stomach. A little bit in the other lung, I'm not sure. But is that being used? Is that something that is being clinically tried now on?
So that's a great question, and it's something that we are actively looking into, and it's something that I mentioned, that this is a very individualized treatment. We would generally only think about using it if we only see a few, 1 or 2 or 3 spots where the cancer is. And if we can safely deliver those high doses of radiation without risk of side effects. If it's too close to an airway or too close to a blood vessel, that there are risks associated with these high doses of radiation. So is it possible? Absolutely, but I think that that's very much an individual conversation about, well, how has the cancer responded to treatment, and what are the sites that we would be thinking about treating at this point?
Yeah, see, they've always told me I was already too far gone for any radiation, that it was stage 4, and that's been 5 years now. But
Yeah.
they tell me that the tests show that what's in my stomach doesn't show up anymore.
So at this
So
point, any time that we would do stereotactic radiation that would be outside of the brain to a few sites of disease, it is investigational. It's something that we are trying to figure out what the optimal way to do that is. Dr. Langer in a moment is going to talk about chemotherapy and the advances in targeted therapies. We have these conversations all the time, but I wouldn't say that there's a clearly defined role.
And I think, as you've pointed out, circumstances change over time. You get some sort of additional treatment, hopefully things are responding, and then the same questions need to be asked again. What might have been true 6 months or a year ago or 3 years ago may not necessarily still be true. So this is a very fluid, ongoing, iterative process that requires constant questioning. And, perhaps an appointment, or at least particularly for some of the newer techniques.
Thank you. Thank you.
Other questions?
Thank you.
It's fun. It's very aerobic.
I had 2 questions. I'll start with one. If someone has, stage 4, and one of the areas that has spread to is the brain, and they started with some whole brain radiation before the chemo. The number of days that they do that whole brain radiation for, have you found that there's a recommended number? Is the longer the better? I mean, this person has had reoccurrence, 6 months later. So, is the likelihood of reoccurrence would have been less had they had more days, or doesn't that matter?
Unfortunately, no. So this is something that we've looked at over many, many years. We've looked at higher doses of radiation over longer periods of time, lower doses of radiation over shorter periods of time. And we've actually studied this and done randomized studies to answer that question. The balance that we have to achieve, and that we're talking with patients about every time that we think about whole brain radiation, is what are the potential benefits versus what are the risks. If we give a higher dose of radiation to the whole brain, there is a higher chance of long-term side effects from the radiation. And so we're constantly walking that balance. What is the optimal treatment in terms of the lower dose, providing control now, versus a higher dose, potentially providing pretty significant long-term side effects. The average is somewhere between 2 and 3 weeks is the dose that has been standard. But the data unfortunately doesn't show that even with 6 weeks of radiation to the brain, that the long-term outcomes are any different.
Okay, and if there were going to be any negative side effects from that whole brain down the road, is down the road 1 year, 5 years? Is there still some 10-year down the road side effect? I mean, is it a gradual buildup of negative side effects?
That's a very, very good question, and a very important question. And I would say that the answer is that everyone is different. We can see the long-term side effects within a year. Sometimes what I have seen is people tell me that they're maybe a little bit more forgetful, that they don't remember where they put their keys, something like that. But those long-term side effects can build up over time, and that's how we came to this intermediate balance dose of 2 to 3 weeks of radiation that has the best long-term lack of risk of side effects with the best short-term control. Does that help?
One other question? Was there another? Sure. Bill?
Hi, my name is Bill Pinchuk. Question, everybody's probably seen Stargate, so the question is one of, is there any potential for the proton devices to target brain?
Absolutely. So that is a huge question that we are thinking about as well. I'll go back to the weeding analogy, and the question that comes up with that is, with proton, there wouldn't be benefit to treating the whole brain, because if we're treating the whole brain, then we wouldn't be able to spare anything with protons. The question about would there be a benefit if we're treating 1 or 2 or 3 lesions, we actually have really incredible techniques using gamma knife, using cyberknife, using these other techniques to deliver those high doses of radiation to those small lesions without delivering much dose of radiation to the other areas in the brain. So that's the technique that we are using. The question of would protons be better, there are some technical challenges with it. The dose to the skin actually is much, much higher with protons than it would be for the others. And so there are some other side effects that I think would make it less likely to be beneficial. But it's a question that we are absolutely exploring and thinking about.
Thank you.
Thank you all. There'll be plenty of time for additional questions. In fact, Ed and Josh will be joining me at the end of my talk, and again, time during lunch. So, without further ado, my talk's going to be a little bit more eclectic than both Josh and Ed, focusing both on advanced disease but also on other aspects of lung cancer, and particularly on clinical trials. So you've heard about very specific modalities. As a medical oncologist, I'm really in charge of more systemic modalities. But again, just a couple words about lung cancer. This is very much a worldwide epidemic, and even as the incidence in the US and the industrialized world seems to decline over time, in developing countries it's becoming more and more ubiquitous. In the past, folks in Asia or Africa didn't have to worry about lung cancer. Unfortunately, they had other calamities to deal with, including infectious illness. Many of them never lived long enough or lived well enough to worry about this. But as the rest of the world improves in their public health, lung cancer is becoming not just an industrial or first world problem, but a third world problem. We've harped on smoking, but I realize many of you are never smokers or minimal past smokers, and in fact, that percentage is going up. Historically, it was 13, 15%. We are starting to look at our numbers, and it's probably closer to 18 or 20%. And I truly believe, although the disease looks the same on an X-ray or under the microscope, it is really, in some ways, a different disease and needs to be approached differently. And really trying to crack really unlock the secrets of lung cancer in never smokers is going to require a lot more work than has happened so far. Ultimately, as both Ed and Josh has pointed out, treatment has to be individualized. We have all these studies and multiple patients, sometimes hundreds, even thousands of patients enrolled on the studies, comparing drug A to drug B or drug A and B to drug B. But every person's an individual, and you have to adapt those findings, really translate those findings to the specific situation. And that's really where the art of medicine comes in. It goes beyond the science. And as both Ed and Josh pointed out, all of this ideally needs to happen in a multidisciplinary collaborative partnership. A single physician or individual cannot manage this illness. So again, I just want to point out some of the doctors that are involved. I apologize, Josh, for not including you because I think I just put the attendings, but it's a burgeoning group in radiation oncology, each with separate interests. Dr. Rangan, as mentioned earlier, is helping to direct the proton treatment. Dr. Simone and Dr. Rangan and Dr. Jones looking at SBRT. You met Dr. Kuharchik before. Some of you have actually had him operate on you. Many other doctors, both at Penn, Presby, and Pennsylvania Hospital, all of which are aligned. Pulmonary division, again, I apologize, Ed, for not including you. This is a slightly older slide, but the three interventional pulmonologists have been here for a while. Drs. Haas and Sturman and Vachani. Dr. Abelda is a translational researcher one of the people I collaborate with continually, and then my burgeoning group in medical oncology, which we hope to expand further. So we talked about tobacco, but what about other causes of cancer? And I alluded earlier to secondhand smoke, perhaps a third of all the never smoking instances. Other aspects of the environment, asbestos never alone, but usually as a cofactor with cigarettes. Radon, lots of controversial information, but thought perhaps to increase the risk. Certainly some pollution for all we know, and certainly we're all exposed to that. Sometimes in the setting of scar, and probably there's a good 5 to 7%, we simply have no idea. It happens, you can't really trace it to any specific event. Nevertheless, we have to deal with it. Again, harping on the smoking, the good news is, at least in the US, over the past 60 to 70 years, smoking rates have halved. In fact, they've more than halved. But over 120 million North Americans are either current or former smokers. Probably the best thing we can do is keep kids from lighting up, obviously. Smokers, unfortunately, do have a reduction in the life expectancy, but if you do quit, the risk goes down. It never quite goes down to the general public. And this is true of many of you who have been diagnosed. More than 50% of those who are diagnosed with lung cancer are former smokers. They did the right thing. Now, who knows? Maybe if the people had continued smoking, it would have happened earlier. It's impossible to really divine that, but the statistics now show repeatedly that probably 60–65% of those diagnosed are not current but former smokers. So just going over advanced disease, I think the two fundamental questions we ask, certainly all of you ask, and certainly I would ask, are, will the treatment improve my duration of life, and will the treatment improve my quality of life? And this becomes a very difficult issue. I frequently see patients who have advanced disease, but they're totally asymptomatic. They have no symptoms. Well, I can't really improve their quality of life, maybe their psychological quality because they're getting some sort of treatment, but not necessarily their physical quality, and you have to balance the side effects which may reduce the quality of life against the prospect, the unknown potential benefit and duration of life. But certainly over the past 20 years, we have abundant evidence that our treatments can improve both. Now, this is a laundry list. I realize most of these drugs are unfamiliar to the majority of you. Some of you can probably pick out the agents that you are on or have been on. But you got to realize I started my career just before 1990. I finished my fellowship in '87, and these were the only drugs available, and they were toxic. We had pitched debates in the 80s and even early 90s. Was treating this disease even worth it? The treatment in many ways seemed to be worse than the disease. The side effects of the treatment in some cases were horrible. In the last 20 years, we've clearly advanced. In green, I've highlighted the drugs we typically use now. And you note, most of these are out of the picture. Occasionally we'll go back to them, but very rarely. Carboplatin made treatment a lot safer. In the 90s, there were a number of other chemo drugs that appeared that were generally more effective and less toxic than many of the older drugs. So for the first time, we were starting to routinely treat patients with lung cancer. And since 2000, a number of other agents, only one of which is a traditional chemo. The rest are targeted agents. They focus on a specific receptor or protein on the outside of the cell. They don't sort of carpet bomb the nucleus of the cells. So erlotinib, which several of you have been on, which targets something called EGFR, bevacizumab, which actually targets the microenvironment around the cancer, the blood vessels that help nourish the cancer, cetuximab, which is an antibody that targets also EGFR, and then the newest agent is crizotinib, just approved a month and a half ago, that targets an enzyme we weren't even aware of 3 years ago that had any role in lung cancer, called ALK, or EML4 ALK. And I'll talk about some of these in some detail. So stage 4, which is really our focus, or recurrent disease, in 1990 it was a big question mark. You think about it, 1990 is not that long ago, 21 years ago. I realize some of you were quite a bit younger, but many of us were adults then, and we had that pitch debate. And now we have not just first, but second, third, even fourth line options. Platinum generally combined with a partner agent, bevacizumab, which we frequently add to it, again, to prevent the blood vessels from growing around the tumor or cutting them off. There's compendia approval, though not formal approval, for something called cetuximab or Erbitux or C225, which we frequently will add. There is second-line treatment now. 4 different drugs are potentially available, and even third-line treatment. And many times we will go back to some agent that was not used in the first-line setting. And in the last year and a half, we have also encountered something called maintenance therapy. Traditionally in the past, certainly up until about 2005, 2006, 2007, we would give 4 to 6 cycles of chemo and then stop. There was no proof at that time that going beyond 4 to 6 cycles was any better than just stopping at that point. Certainly side effects seem to be cumulative. Now, in the last 2 to 3 years, there are 2 specific agents, both pemetrexed or Alimta, and then erlotinib, also known as Tarceva, which clearly extends survival. And if they're done properly at the right doses, we can minimize the side effects. So people often wonder, and the question I typically get, it's an unanswerable question, how much time do I have? We don't know that. I've seen people I could have predicted would live years who only live 6 months. I've seen people who really look to be in horrible shape. You might expect to live 4 to 6 months or out years. But there are specific prognostic determinants. Stage, which I think most of you are familiar with, it has to do with the tumor size, the nodal status, and whether the tumor is spread. But even within stage 4, there are differences. Disease that's still confined to the chest as opposed to disease that's spread beyond the chest. Performance status. You'll often hear your practitioner ask how functional you are. What are you doing? I mean, it sounds like idle chit-chat, but it's not. We are trying to determine how much people are up and about, how active they are, how able they are to do their normal activities, their ADLs, their activities of daily living. Those are up and about, and without symptoms, obviously, as you'd intuitively expect, are going to do better. Somebody who's spending half their time in bed, performance status 2 or 3, they're not going to do so well. It's a very obvious system, but it's a crucial determinant. Weight loss, again, a major determinant. We track weight. We'll often ask how much weight have you lost in the interim period. People who haven't lost weight tend to do better. And apologies to all the men in the audience, but women always do better. Lots of theories behind that. Is it estrogen? Is it the fact that they just take better care of themselves? In fact, there have been studies done both in locally advanced lung cancer and head and neck cancer that have looked at partnership status. And women, whether they're partnered or not, seem to do just as well. But men who are unpartnered do worse than men who are partnered. So, you know, some folks have joked if you're unmarried and male, you probably the first thing you should do is get married, or at least have a partner, somebody who's willing to do it. So when it comes to therapeutic determinants, gender falls by the wayside and other factors come up. Obviously, stage, performance status, weight loss are crucial. But these are the 2 factors now in advanced disease that really determine which treatment we choose. Histology refers to the pathology, the way it looks under the microscope. I'm going to show you a couple of photomicrographs. And then increasingly molecular markers. And these are just the first 2. There will be others. There better be others. But these are the 2 that are what we call actionable. We actually have agents that can target that. So we've sort of abandoned our one-size-fits-all approach, and now we pay attention not just to the demographics, the stuff I can glean in the first minute, stage, performance status, comorbidities, or other illnesses that may influence outcome, but we also look at histology and specific markers. So, yeah, it's so frustrating. You get a biopsy. Why the heck can't they give you the result within 12 or 24 hours? Well, it takes a while. They have to stretch it on a microscope. They have to do special stains. And then even beyond that, have to do marker tests. So this is what they're looking at under the microscope. This is what tumors frequently look like. Now, I know unless you have a biology background, this is semi-meaningless. But you can see this very different appearance between adenocarcinoma and squamous. We call this keratin pearls, this sort of amorphous pink substance that appears. You don't see glands here. You see obvious glandular formation with what we call vacuoles in the center, spaces in between the cancer cells. So a pure squamous, a pure adenocarcinoma are very easy to distinguish. But sometimes you get pathology like this where there's a lot of question marks. Is it adeno? Is it squamous? Is it both? Ideally, the more tissue we have, the better. So In the 80s and 90s, we sort of backtracked. We used fine needle aspirates. We just wanted enough tissue to make a diagnosis. Now, as our treatment has evolved and it becomes more histology dependent and marker dependent, we need more tissue. So unfortunately, in many cases, we have to get more invasive. We have to get core biopsies instead of needle biopsies. Obviously, this is highly dependent on the experience of the pathologist and underscores the silent partner you guys never see, the pathologists. They don't come to the meetings. They certainly don't come to the clinic, but they're behind the scenes looking at these slides. We are constantly conferring with them, constantly bugging them, because just like you, we're impatient for the results. So this is one of the first trials that actually put histology on focus. Bevacizumab or Avastin is the agent I've alluded to earlier that focuses on blood vessels. There was a trial comparing standard chemo to chemo plus Avastin. Don't focus on the numbers, but just the difference here, what we call the p-value. That's the likelihood that a difference is real. If it's less than 0.05, that means 19 times out of 20, the improvement in outcome is due to the agent that's been used. If it's 0.03, it means 97 times out of 100 it's due to that. And clearly the Avastin drug led to better outcomes. This was all comers. And some of you have been on this agent. Some of you have family members have been on this agent. Some have been on it and off it and then back on it. But we feel that it's one of the crucial agents in our therapeutic portfolio, and it specifically works best in non-squamous. 2000, we didn't care. Squamous, adeno, we treated it all the same. But now non-squamous has a specific drug. And the same holds true with this drug, pemetrexed or Alimta. Big trial. I considered this the height of corporate opportunism. Lilly Pharmaceutical makes both Gem and Pem, gemcitabine and pemetrexed. So if I were the CEO of Lilly, I would have done the same trial. Gemcitabine is an older drug. It's running out of patent life. Eventually, they won't be able to charge the high cost that they can. It becomes generic. Other companies can make it. So this company, from its bottom line standpoint, wisely decided to compare this combination to Alimta and platinum. Alimta is a newer drug, had just been approved in the second line. Very few academics involved themselves in this study because we basically thought it was a corporate study. It really wasn't necessarily going to advance research. But they were very smart. They included histology as a determinant, adeno versus squamous. And in fact, this drug worked better in adenocarcinoma than gemcitabine. Actually led to an improved survival. Conversely, this drug, gemcitabine, worked better in the squamous cell points. So all of a sudden now, and this is just in the last 2 to 3 years, we have different drugs working differently in different histologies. Now, it doesn't mean Gem doesn't work in adeno, but compared to Pem, it definitely works better in squamous. Pem's approval right now is strictly limited to adenocarcinoma. So here's our standard cytotoxic platforms. For adenocarcinoma, we'll give platinum plus either pemetrexed or Alimta or one of the taxanes, paclitaxel or docetaxel. For squamous, platinum plus either gemcitabine or the taxanes. You can see taxanes are common pathway for both. What about combining both? Obviously, well, pemetrexed is better and bevacizumab. Other data looking at all three. And several of you have been on the regimens that have looked at. Is it safe? Is it feasible? And is it better? This is a study that was done about 2.5, 3 years ago. It was just published 2 years ago in one of our major journals, combining carbo, which is always sort of the platform drug, with both pemetrexed and bevacizumab, and then actually continuing these two drugs together, Pem and Bev, stopping the carbo after 6 cycles. Again, don't concentrate on these numbers. Everybody's an individual. Historically, in the past, in the 80s, it was 4 to 6 months, 14 months in this study. I am absolutely convinced we can get to 18, 24 months. But nevertheless, much higher response rates, much higher progression-free survival, a clear benefit, at least ostensibly, and now a phase 3 trial, and I'll go into that shortly, what that means, comparing the older regimen, carbo-pac-bev, to carbo-pem-bev. Is it really better? Or is it just safer? Or is there no difference? This study has finished accrual. There were 900 patients, like many of you who enrolled on this trial, didn't have a choice. It was a computerized coin toss. Either get Pem or PAC. Everybody gets carbo and bev. You can see they have different maintenance regimens. The results will probably be out in the next 4 to 6 months, and it will influence how we treat patients with non-small cell. In my last few minutes, I want to talk about molecular markers. Again, 2001, at least with respect to adenocarcinoma, was a big blue circle. We had no real molecular understanding of this entity. 2011, more than half of patients with adenocarcinoma have one or another specific mutation on the tissue, what we call tissue typing. EGFR, the target of Tarceva or Olatinib, EML4ALK, the newest actionable marker that's targeted by Crizotinib. KRAS and BRAF have been around for a while. KRAS, we haven't quite figured out the agent yet that will work in this. That's a major area of research. BRAF is one of the targets for melanoma. Well, 1 to 3% of people with lung cancer have BRAF. Might the same new agents that work in melanoma also work in lung cancer? Obviously an area of research. I know I'm not going to question people's political beliefs, but many people have been critical of the, quote, stimulus. This is actually a stimulus study. 1,000 patients enrolled from multiple institutions who were all newly diagnosed, had their tissue looked at. They had to provide informed consent. They went to a central confirmation to see whether it was adenocarcinoma, one slide to confirm the diagnosis, and then they went through a number of mutational analyses. The 3 that I've mentioned, some newer ones, some that we don't necessarily have drugs for yet. It was reported to a database, so it could be stored, and also reported to the individual physicians, and then used to select treatment. And in fact, there was a whole panel of various treatments that are available. And here's the breakdown. And this is pretty much in keeping with what we're seeing. About 20-25% will be positive for KRAS. EGFR, this may be a little bit high, but it's at least 10 to 15%. EML4ALK, or ALK translocation is about 7%. So over 50%, 54% in fact, had some sort of marker. Now the problem is we haven't quite figured out the drugs that can attack these markers, and you can see it's going to be tough. These are much rarer. But ultimately, I'm convinced 1 or more of those will be actionable, and we need to figure out what's going on here, where no obvious mutations have been detected. And here are examples of some of the drugs, some of which are approved, like Crizotinib or Olatinib, and some which are still investigational, are being looked at with specific markers. And because we do at Penn and elsewhere have such a large population with KRAS, we are joining some of the studies that are looking specifically at agents that work on KRAS. Well, why is this important? Why are we so compelled to check markers? The original data for this came from Asia. EGFR, the mutation I alluded to that's the target of Tarceva, is much more common in Asians. It's more common in adenocarcinoma, woman, never or light former smokers. So this was a big trial in adenocarcinoma comparing gefitinib to standard chemo, carbo and Taxol, over 1,200 patients. And what they did is they went back and actually looked at the markers. Now this isn't survival, this is just time to progression. So in green are those who had, this is the mutation positive group. In green are those who got gefitinib, which is like erlotinib. You can see they did much better than chemo. Those who did not have the mutation, in fact, did better with chemotherapy, which is shown in this sort of orange-yellow color. So all of a sudden, we had markers making a distinction in outcome, actually sort of pointing the way in terms of which agents might work best. Here's response rate. Now, when we use the term response rate, we're talking about actual shrinkage. And those of you who have been with me in clinic, and pretty much true of most of our physicians, we'll show you the films. So we've got to see for ourselves whether the drugs are working, whether things are stable or actually shrinking. Sometimes we don't necessarily, apologies to Dr. Tarigian who's not in the room, sometimes we don't always believe the radiology reports. We've got to confirm it for ourselves. But in the case of gefitinib in mutation-positive patients, over 70% had a major response. Intriguingly, chemotherapy also did a bit better in that group than it did in the what we call the wild-type or non-mutated group. And then EML4ALK is a newly discovered translocation only in the last 5 years. It says 4%, but I'm convinced it's probably higher, along the lines of 7 or 8%. And this is called a waterfall plot. And just to walk you through it, on the x-axis, on the flat axis, is each individual patient. On the y-axis, the vertical axis, is the amount of shrinkage. So anything with a minus sign means shrinkage. So people had the ALK translocation. You can see the vast majority had shrinkage. We consider a partial response at least a 30% shrinkage, and anything in green here is a PR. CR means you can't find it anymore on the films, and you can see a few lucky individuals were in that group. Relatively small percentage actually had tumor grow. So we want to see a waterfall type effect whenever we look at a new agent. If it's not showing this sort of effect, you really have to question whether that new agent is having any benefit. And then, of course, a number of new agents. I've already alluded to erlotinib, crizotinib. Cetuximab is not yet approved, although it does have quote-unquote compendia approval. So depending on the insurance company, you can sometimes add it in. There are newer angiogenesis inhibitors that hold some promise. PARP inhibitors, MEK inhibitors. I know it's sort of an alphabet soup of various enzyme systems, but these are all specific targeted therapies. They're not our traditional chemo. And when I discuss systemic treatment with patients and their families, I don't always use the term chemo. I use systemic, and then I say either chemo or targeted, because there's a tendency to confuse the two. They're very different ways they work, and also very different toxicities. Tarceva does not cause hair loss, doesn't affect the blood counts the way traditional chemo. It has other side effects. Causes diarrhea, can sometimes cause a pretty nasty acne-like rash, but we know how to deal with these. And then small cell, which is really being focused in another room, some other areas of interest that probably don't have much effect in non-small cell. Last couple minutes, some of our ongoing research. This is actually, many of you know, about 10, 15 years ago, each of the states got a huge settlement from the tobacco companies. The state's attorney general used this money. Some states used it to fill potholes. Pennsylvania, fortunately, actually has used it for medical research, as it should be. And we are actually getting some of this money specifically for lung cancer research. And Neil Vachani and I are routinely testing basically every new patient we see is going to stay with us for EGFR and KRAS, who has adenocarcinoma or mixed squamous and adeno, and we're putting all that data into a biobank. We're looking at tumor tissue. We're also collecting blood and urine. It's a heck of a lot easier to get blood than to do biopsies all the time. So if we can figure out how to find markers in the blood, we'll be far better off. Dr. Evans, who you may have met briefly earlier, and some of you are her patient, is looking at erlotinib in a much earlier setting in folks who have the mutation. We're looking at the son of erlotinib. It now has a name called afatinib, comparing it to chemo and actually combining it with other agents in patients who've progressed on erlotinib, and doing additional studies with crizotinib, and I know some of you have been on that agent. It's just, as I said, just since August that drug was approved. This really goes for locally advanced, but I think it's important to mention the proton beam machine is being looked at specifically in folks who have locally advanced disease that's not spread beyond the chest, combining it with conventional chemotherapy, both as a definitive treatment or as a preoperative treatment. We're quite excited about that research, and again, Dr. Rangan is involved. Malignant mesothelioma is next door, but there's a number of new immunologic therapies that are being looked at, including interferon, TGF-beta, and it's a rare disease, but if you know anybody with mesothelioma, they really should be seen at least once, if not continually, at the Plural Center. And then we're trying to teach old agents new tricks. So nifenavir is actually an AIDS drug, not obviously active in lung cancer, but in the lab, in culture, it seems to be a radiosensitizer. It makes radiation work better. So we are actually looking at this in combination with chemo and radiation in locally advanced disease. Valproic acid is a seizure drug, but it seems to be a chemosensitizer, specifically in small cell. So here, too, we're eager to look at drugs like valproic acid in that setting. This is the clinical trial hierarchy, and I think one thing that we'll always encourage folks to do, if a trial is available, is to enroll on it. So the earliest stage of testing is experimental, phase 1. A new agent or a new combination of established agents. Our goal, of course, is to get a response, but the trial's goal is to establish the top safe dose, what we call the MTD, or the maximally tolerated dose, or optimal biologic dose. This sometimes requires tumor biopsies or frequent blood draws. It's usually reserved for folks with tumors where there's no standard treatment or standard treatments have been exhausted, but this is where crizotinib and erlotinib ultimately came from initially. Phase 2, systemic agents are applied to multiple patients with a specific disease. So that study that I showed you before looking at Avastin with Alimta and Carbo is an example of a phase 2. The goal is to look at side effects and feasibility and activity. We want to see a high response rate. We want to extend the time till the disease starts to grow again and obviously extend survival. And then the acid test, the crucible of testing, is phase 3. comparing a new standard combination, a standard agent, to a newer agent or newer combination. This is tough because you don't get to pick and choose which regimen you go on. It's a computerized coin cost. Neither the doc nor the patient can actually select the treatment. And people worry, oh, is there a placebo involved? If the standard treatment is no treatment, then placebos make sense. But if the standard treatment is an active therapy, then you have to have some sort of active treatment. There's a lot of problems with clinical trials. It's very labor intensive and costly. Our government, as you're well aware, is in an era of austerity, so it's harder to get funding from the NCI, and a lot of myths and perceptions that exist about clinical trials. The notion that you're somehow going to be a guinea pig. Well, that's wrong. These are carefully conducted. They mandate institution review board approval, which includes doctors and nurses and pharmacists, but also lay people like yourself, survivors, clergy members, intensive monitoring, close follow-up. Got to give informed consent. Alternative therapies need to be discussed. You cannot be coerced. You can always beg off the treatment. They limit the total accrual, mostly to limit side effects. Sometimes we rail against that because it's doing good and we want to expand the accrual. Any adverse events have to be reported to the IRB, and obviously any excessive adverse events can cause the trial to close. FDA can also look at these trials and look at the data. A very important fact, those who enroll on clinical trials seem to do as well, if not better, than patients who are treated off protocol. And part of that may be the nursing support. We're just focusing on patients more, focusing on side effects and symptoms, perhaps being a little bit more proactive. And costs, which concern many, are only about 10% higher than standard care. You are not a guinea pig. You can opt out of a clinical trial at any point at will without compromise to subsequent care. And conversely, the doctors or nurses can halt your involvement if they think it's harming you. These are the questions you should always ask. And if any of you have been a patient of mine, you know I encourage people to ask questions. I encourage you to write them down so at least you can remember what we say, or even bring a tape recorder. What are the most common side effects? What causes the side effects? How can I prevent or minimize the side effects? Do you have any printed material? Can I take other medicines while I'm receiving treatment? How do I know if it's working? Again, the scans. Can I speak with someone else on a one-to-one basis that had similar treatment experience? That's a little bit tough, but we usually have volunteers. What other options do I have? Is there financial assistance, particularly with some of these huge co-pays that exist? How can I help? We do have some representatives from financial services. How can I help other patients? Again, anybody who's gone through this, like Donna Lee and others within the room, know that there's an altruistic impulse. If you've gone through it successfully, there is a desire, in fact, sometimes a joy in sharing the experience and helping others get through the experience. Other questions, what are the true expectations? Is it going to extend my survival? Will it palliate my symptoms? Is it experimental? What do you do if treatment doesn't work? What are the options? And can I stop treatment early, and what are the consequences? Finally, this is an alliance. And I'm going to introduce Nancy later, talk a little bit about this, but it's absolutely crucial that patients and families ally with the doctors. This is not a paternalistic system. Silence equals denial as far as I'm concerned, so you've got to articulate, advocate, and ally with your docs. And if I can call Ed and Josh back up for our last 5 to 10 minutes so we can have questions. I thank you for your attention. Yes. Right there. Yeah, you.
No, I'm
Oh, you're. You're the coordinator. Bill?
Two questions. Number one, can tumors that shrink significantly regrow?
Unfortunately, yes. And that's the bane of our existence. Tumors can regrow where they are, so where we see them on films. Now, we sometimes get into a situation where other smaller tumors have disappeared. The original primary tumor shrunk, but then started to grow. That's where I may involve Dr. Jones to consider CyberKnife or some other technique for that area. It's a controversial topic, but particularly if it's causing symptoms, it would merit it. Now, there's another variable, and some of you have experienced this. It may never come back where it was, but it pops up someplace else. That's the same scenario. Presumably, there is some sort of genetic resistance in that cell that causes it to come back in a different area. And that usually means you have to start different treatment or add another treatment to the current treatment. Now, if it's an isolated spot, sometimes we can take it out. If it's isolated, we might be able to do CyberKnife. If it's isolated in the lung, in the parenchyma in the lung or within the airway, Dr. Moon may have some sort of modality, but you can see it's a very much a joint interdisciplinary effort. You had a second question?
A second question is, how does tumor shrinkage in your waterfall chart relate to life expectancy?
Excellent question. Not always a one-to-one relationship. So, and again, I emphasize the fact that patients are individual. I'd like my partners here to comment on this as well. We sometimes see major responses, but unfortunately they're very brief. It's like a flash in the pan response. Things shrink and then within 4 months they're growing again. Sometimes we see much more gradual responses. It's only 20% better at 3 months, 30% better at 4 months. Those often are much longer lasting, and there's just no predictability. In general, though, the more shrinkage you see, the more likelihood that patient's going to live longer. Not always the case, though. I've had some patients go through innumerable treatments, no discernible shrinkage, but no discernible growth or minimal growth as well, and they've lived longer and lived better than they might have otherwise. Josh?
And I would echo that. Again, in those circumstances when we've had a good response to therapy and we see that things are shrinking and responding well to the systemic treatments that Dr. Langer and his team offer, we're considering more and more using CyberKnife, and I don't want to just say CyberKnife, but stereotactic treatment, because there are lots of reasons that perhaps there may be another machine that might be better, but using radiation or using a more local therapy to try to get at that area that has responded but may still persist.
Question over
Hi,
here.
Thank
Dr.
you.
Langer, you said your new patients all are tested for markers. Old patients, there's no reason.
Old patients are also tested
Oh,
for
okay.
markers. Or more established patients. They're not necessarily old. Some people have been in the situation where they were diagnosed before some of these marker tests were available. So what we'll often do is go back to the original tissue, if we can get it, if it's sufficient, and query that tissue for the markers. It becomes a bit of a challenge because sometimes the original operation or biopsy was done in an outside hospital. We've got to retrieve it. Sometimes that outside hospital has actually worked it up. Most times they haven't. We will generally test all or nearly all folks who have adenocarcinoma, and anybody who has what we call NOS, not otherwise specified. We can't quite figure it out.
Or non-differentiated.
Undifferentiated or mixed adenosquame. The one group we do not tend to test are pure squamous. These markers that I mentioned just by and large do not exist in pure squamous. The one exception there is somebody with squamous cell carcinoma has never smoked. As far as I'm concerned, they should be tested just as much as adenocarcinoma. We do not yet have established markers for squamous, although there is work on that. About 25% of folks with squamous harbor a receptor called FGF, fibroblast growth factor, and we're developing drugs for that. So again, stay tuned. And small cell, unfortunately, we do not have any established markers.
And also, real quick, as far as maintenance drugs, I was diagnosed stage 4.5 years ago.
Mm-hmm.
And Dr. Evans said she would have put me on that had it been protocol, I guess. To do that.
4.5 years
Never
ago was
did.
not.
It's not. So how do you know whether, I mean, everyone's different, I understand
So
that.
you would have been one of the people in the control arm that did really well. The maintenance
So
treatment
there's
with
no reason to be on it now.
No. The only reason, particularly if you're out that far, I think it's more of a discussion or debate if you're a month or 2 months out. I and my nurses, Susie is here, Vicky is not, will often go into the pros and cons of that. Because remember, if you're on treatment, there's still the possibility of side effects. And in some cases, now these drugs are relatively less toxic, but even Alimta can cause cumulative toxicity. We have people are noting sometimes more fatigue. Some folks get tearing, hyperlacrimation, or puffiness around their eyes. I mean, they're not major side effects, but it's annoying. And so 4.5 years, unless something's growing, I'd sit tight and get regular surveillance scans.
If I can, just while we're on the subject of testing, I've had patients come in and
get tired of testing being cut and having needles in them, and they say, stop testing me, just start treatment. I do want to say that although there are rare times, and maybe more than rare times, where it's truly because we don't know what to do with the individual, most of the time we ask for further testing and more tissue, because as we're getting into the era of targeted therapy, we want to give the first go around, especially if there are side effects involved, the best shot, the most bang for your buck in terms of treatment. So
typically, at that point, we'll use usually a combination regimen, unless somebody has the mutation where we'll use tarceva-erlotinib first. For subsequent treatments, it's usually one or seldom more than 2 drugs at a time, usually 1 or 2. We'll often re-involve Dr. Moon and his colleagues when our initial test just shows cancer and we can't really do the markers or figure out whether it's squamous or adenous. So not infrequently we're asking again for another biopsy, not so much to establish diagnosis, but so we can differentiate the type of treatment that's should be ideally used. At some point, the same may hold true in radiation as well, but I don't think we're quite there yet.
You mentioned needle biopsies or core biopsies as possibilities to get the different markers. So if somebody had the needle biopsies, does that provide enough information as these new markers become available in terms of knowledge about them? Does that person's data in wherever you store that, how does that, move forward for that individual?
The answer is sometimes. It depends. It's not just the biopsy and the amount of material, it's the cellularity of the biopsy. In other words, how many tumor cells are actually in the sample. If there's a lot of scar tissue or inflammation, even with the core biopsy, you may have relatively few cells and really not enough tissue for testing. Conversely, sometimes have a small sample and there are enough cells to test. But this is a situation, particularly if the tissue's been depleted, and it often is, where we will have to rebiopsy. And Dr. Moon may not have seen the patient for a couple of years, but all of a sudden he gets re-involved. Or interventional radiology gets involved. There are a number of different ways to go about this. Yes?
Thank you.
Last 2 questions.
Okay. My daughter has had the whole brain radiation, 10 treatments, and also 8 months later she had gamma knife treatment, three lesions. Question is for Dr. Jones. Yeah, would she be a candidate for any radiation in the future? If she were, would whole brain be not something, or would she be more likely to get gamma?
That is a really important question, and again, it's very individualized.
Right.
This is something that we're seeing more and more as Dr. Langer's targeted agents are doing more as people are living much longer. We're seeing spots coming back in other areas in the brain, and we are sometimes doing gamma knife. There are times when we would recommend a long way out from the whole brain radiation, repeat radiation. It's an involved conversation. It's an important conversation, but there are options. Okay. So I don't know the specifics, but that there are options.
Okay. So, and the other thing and I think some of you have experienced this unfortunately firsthand, our systemic agents by and large unfortunately do not get into the brain as well as we'd like. Certainly the standard chemo has a tough time doing that. Some of the smaller agents, some of the newer, smaller molecules can cross this fatty blood-brain barrier. When you think about it, this membrane that sort of separates the brain from the circulation is there for our protection. If we accidentally ingest a poison, it keeps it from going to our brain, one of our most vulnerable organs. Well, unfortunately, it also keeps the systemic treatment that would attack the cancer from getting into the brain. So I have to echo Dr. Jones's comments. If a single lesion comes back, sometimes some remove, CyberKnife or gamma knife would be the preference. If it's multiple lesions, it becomes a lot harder, even up front or no matter what the timing is. Time for one last question.
I have 2, but I think they're
2
quick
last
ones.
questions. And then I think we really do have to, there'll be plenty of time to ask questions individually.
One question about the CyberKnife technology. Is that being used outside of the brain and the lung at this point?
Yes.
My understanding was that was limited to the brain and the lung.
So gamma knife is the helmet that I showed the picture of, which is limited really just to the brain. CyberKnife uses that machine that's mounted on a robotic arm, so that actually can be directed anywhere in the body. We do have to have a way of tracking to make sure that we are targeting exactly where we want to target because of that robotic arm. So very often with CyberKnife, we're putting in markers called fiducials, like a little gold seed, that we can then track, and the robotic arm actually moves and targets that area. That can be in bone, that can be along the spine, that can be in the lung, that can be lots of different areas on the body.
Okay, thank you. And my last one, I think, Langer, Avastin has gotten a lot of press for being withdrawn from use.
Breast cancer.
I know, breast cancer. This goes to my question. Is that an economic issue? And, you know, there's a lot of other stuff for breast cancer now. Or does the drug treat different cancers differently?
Your second point is the right answer. The drug works differently in different cancers. Avastin was and still is a major breakthrough. This is an antibody, so it's not a typical chemo drug that targets specifically the blood vessels. It doesn't actually work on the cancer cell, but the microvessels that surround the cancer, and it specifically targets growing blood vessels. So established adults have established blood vessels. It doesn't usually attack those vessels, certainly the bigger vessels. It's shown its greatest benefit in lung cancer and in GI cancers, and colorectal cancer, believe it or not. Its original approval is actually in colorectal cancer, and there it showed a survival benefit. And in lung cancer, it also showed a survival benefit. The problem with breast cancer, and I guess we're a little bit off topic, but I think it's a major concern, is it showed a delay in time to progression, actually a major delay. It doubled the time that tumors actually started growing again. But unfortunately, that did not translate into a reliable, consistent survival advantage. And that's partly because in breast cancer, way before lung cancer, we had multiple treatments. People could get first-line treatment, second, third, fourth, so it diluted the benefit. So the decision to approve and then withdraw the approval has been very controversial. Without question, I think there are women out there who have breast cancer who are benefiting from the drug. I do not, as a means of reassurance, I do not foresee that happening with lung cancer. I think people like me would be marching on Washington if it happened. It's one thing to make advances, even if they're relatively baby steps, but to withdraw advances is absolutely antithetical to just the zeitgeist of the U.S. So I think with that, I will end this session. It's been very good, very informative, and I particularly want to thank my co-speakers, Dr. Moon and Dr. Jones. I think, Nancy, are you up now? My privilege to introduce Nancy Gatchett. I think most of you are getting lunch as we do this. If you look at the front page, this has been co-sponsored by the Pennsylvania Lung Cancer Partnership. Nancy's in charge of that. She is a major advocate. She has actually hooked me up with several patients. Some of my most interesting and challenging and most endearing patients have come from Nancy, and she'll have a few words as well while you guys are coming up. The stairs are over there.
Thank you. Thank you, Corey. Hi, it's my pleasure to be back here again this year. Second time we're co-presenting Focus on Lung Cancer with Abramson Cancer Center. I love Corey. I think he's leads a fabulous team here at Penn. And I just wanted to follow up for a second on something he said. He talked about clinical trials and how important they are. If any of you are thinking about clinical trial, don't know how to think about it, back at our table we have DVDs that tell about 4 patients in their own voices who made the decision to participate in a clinical trial. It can help you in your thought process. So stop by and see us. So anyway, Pennsylvania Lung Cancer Partnership, we're the second state chapter of the National Lung Cancer Partnership. Our mission is to decrease deaths due to lung cancer and to help patients live longer and better. It's pretty simple. The Pennsylvania Lung Cancer Partnership brings this lung cancer advocacy right here into our own community. So what have we done here in the Pennsylvania area? Well, we funded Sunil Singhal, who is a doctor at the University of Pennsylvania, and he went on to get major governmental funding. We've worked with the cancer support community in presenting Frankly Speaking about lung cancer. It's an event similar to this, a little smaller scale, and we participate in their monthly lung cancer networking group and try to get people there for the support they might not get in their lung cancer journey otherwise. So if you were looking for a support group, the second Saturday of every month at 10:30 in the morning, there's a group of survivors who meet at the Cancer Support Community in Fairmount Park. There's information at their table in the back. We did an advocacy training session this summer. We'll be doing another one in 2012 right here in the community. So people who want to make a difference in the world of lung cancer, we offer you a variety of options to do that. We also, coming up in just a couple of weeks, is the largest free-to-breathe 5K rally, run, and walk in the country. It was the first event ever was held here in Philadelphia in 2006 when I was in treatment for lung cancer. When I came out of treatment, I felt I had to make a difference, and I joined with the National Lung Cancer Partnership to make a difference in this disease. But we raise a lot of money at this event, and it gets plowed back into research and into awareness programs. When I stop talking, you'll see our newest PSA, which will promote our event, and I hope you like it. It will be airing on ABC here in the Philadelphia area. This year we also partnered with Nydia Hahn, who's a consumer reporter and weekend anchor on 6 ABC. Watch late afternoon, I'm not sure whether it's 4:30, 5 o'clock newscast, the first week in November. They're doing a 4-part series on lung cancer, and it will feature our own Dr. Langer here, as well as patients who have been treated at Penn, but it will bring a broader awareness to the challenges that this disease faces. So I'm really very excited that ABC was willing to partner with us to bring that story to a broader audience. If you have any questions about how you can get involved beyond being treated for lung cancer, how to make a difference, stop by our table, talk to us, work with us. We want to make a difference. We want to make the lives of the people we love a lot better. Thanks so much for being here today. Sure, thank you.
Nancy, thank you so much. And again, they have a table in the back. A lot of good things come from this. Very proactive a group that is really a home that's local, Pennsylvania. Huh? Is the PSA here? So, so here's the PSA.
Join us in our journey to defeat lung cancer. Find an event at freetobreathe.org.
Very nice. Particularly like the way everybody's going in and out. It's the first time I've seen the human simulation of lungs. So again, there are resource tables, again, all around the room. Those of you who finished lunch early. Individual doctors will be back in each of these rooms at their tables. I'll be sitting over there. I'll be happy to answer questions or just shoot the breeze. And certainly we have another hour at the end between 1 and 2 where we'll talk about integrative therapy and managing side effects. So again, a little time for relaxation and impromptu dialogue. Thank you.